Assalamualaikum and good morning, everyone. Welcome to the virtual ultrasound guided regional anesthesia workshop 2021, the future of RA in our ED. This workshop is jointly organized by Persatuan Dr Anaesthesia Hospital Kuala Lumpur, Special Interest Group in Regional Anesthesia Hospital Kuala Lumpur, and Ultrasound Guided Regional Anesthesia Emergency and Trauma Department Hospital Kuala Lumpur. Okay. I am Najwa, Medical Officer from EDHKL, and I will be your moderator for today. First and foremost, on behalf of UGRA, Ultrasound Guided Regional Anesthesia EDHKL, I would like to thank our anesthesia team for all their efforts to help establish regional anesthesia in our emergency department. The objective of today's workshop is to introduce regional anesthesia in the emergency setting to provide clinicians with a new modality of pain control. We are very pleased to have a panel of esteemed speakers who are experts in their field and also very eager to share their vast knowledge and experience with those present today. For today's workshop, we will be listening to a series of lectures focusing on upper limb, lower limb, and truncal blocks in emergency department, including a brief history about setting up the regional anesthesia in emergency department, and also pharmacological considerations on and complications in RA. Each of these lectures will be followed by a demo of respective blocks. We will also have a pop quiz in between lectures and some exciting prizes to be won. So stay tuned. At the end of the workshop, we will have a live Q&A session, so feel free to type in your questions in the chat box if you're viewing through YouTube or Zoom, and we will do our best to accommodate all of them. Before we start, there's a few housekeeping rules that everyone needs to remember. Please mute your microphone so as to not to interrupt the speakers throughout the workshop. For questions, please type according to the following format. State your name, where you are from, and your question. And don't forget to register your attendance by scanning the QR code on the screen or clicking the link in our chat box. Also, don't forget to scan the QR code to claim your CPD points. And bear in mind, please fill in using your full name and IC number. So last but not least, your certificates will be emailed to you in the coming weeks. All right. Without further ado, to officiate the opening of this workshop, I would like to invite two renowned experts in regional anesthesia to give the opening speech. Just a little introduction about our two speakers. Our first speaker is Dr. Hidayah Shafi. She is a consultant emergency physician in our emergency and trauma department in HKL. And she has a fellowship in emergency critical care under Ministry of Health and also a fellowship in critical care ultrasound by WinFocus as well. She is also our in-house EDHKL training coordinator. Our second speaker will be Dr. Amiruddin bin Nik Muhammad Kamil. He is a consultant anesthesiologist in Hospital Kuala Lumpur. He's the lead person for regional anesthesia program under Ministry of Health and was also the first European diploma in regional anesthesia holder. So please welcome Dr. Hidayah and Dr. Amir.
Assalamualaikum and a very good morning. I'm Dr. Hidayah Shafi'i, the Training Coordinator in Emergency and Trauma Department HKL. 4 years ago, we noticed that we have quite a number of emergency physicians in our department. We also have many ultrasound machines, one in each zone. But more than anything else, we have patients, a lot of patients, around 500 to 600 per day. And majority of them were in pain. We thought this was an ideal environment for ultrasound guided regional anesthesia service. But what was missing from the picture was the RA skill. So I decided to join the HKL NS Special Group Interest in Regional Anesthesia or CIGRA for 1 month in October 2017. And I personally performed 50 cases and assisted many more. And I enjoyed it immensely. So we immediately collaborated, conducting ultrasound guided RA courses for both our NS and also EDMOs. And today actually marks our 5th collaboration, the 2nd online course in this COVID-19 pandemic era. However, a year afterwards, we found that individual skill was not enough. We did not have enough doctors with RA skill or proper pathway for RA cases in our ED. So having ultrasound skill and having attended only 1 course was inadequate for us to practice, especially without supervision. There was no credential and also privileging program, and as a result, only few of RA cases were conducted. So what we did in 2019, we handpicked few emergency physicians and also MOs to form a dedicated ED-RA group. The selected MO had a prerequisite of graduating from our SonoCam program. So this team had worked very hard to establish end-to-end system in ED, from patient recruitment to performing blocks and also following them up. So the team member also required to fill up their logbooks for CNP process. So they were supervised by Anesthesia and also emergency critical care physician and trauma fellow during the block process. Now the RA team has their own RA suite with a dedicated MO and also ultrasound machine during office hour on weekdays. So I'm sure Dr. Shamala will tell you in details about this in her lecture later. Until now, we have performed more than 120 blocks of various types, from interscalene to ESP to pop detail without any complication. And this also leads to better patient satisfaction level. We are still at our infancy stage. There are a lot more to learn and to explore, but we aim to become the RA training center for emergency fraternity in 5 years' time. Now I have announced this to the world, so let us work hard, EDHKL RA team. And last but not least, I would like to take this opportunity to thank the EDHKL RA and also AV team for their hard work for the last few years, especially during this tough pandemic time. And also million of thanks to the HKL and CIGRA for their guidance, effort, time and also opportunity provided to our team. And also to our HOD, Dr. Mada Abdul Wahab, for his support, and the whole department for their never-ending belief in us. Okay. To all participants, we hope that virtual course will create at least some awareness of the ultrasound-guided regional anesthesia service in ED, and we hope to share our experience, what we have learned. If you want to walk fast, you walk alone. But if you want to go far, we walk together. So enjoy the course and see you in December for the hands-on session. Thank you.
Assalamualaikum and good morning to everyone. Firstly, my heartiest congratulations especially to the organizing committee for their time and effort they have given to this workshop to make it a success. Not forgetting to the excellent job from the speakers who give their time to prepare the slides and the speech besides their busy clinical daily activities. I think more than 20 years ago, our fathers, grandfathers, great-grandfathers had no access to the regional, ultrasound access. Regional block was performed with the help of nerve stimulator attached to a needle to locate a nerve. Surface anatomical landmark was so important to determine the exact and precise location of the block needle insertion. I still remember among the early blocks that I had performed using nerve stimulator was in a patient for plating radius ulna. So the night before the surgery, I had read something on supraclavicular brachial plexus block. And during that time, there were neither smartphone nor Mr. Google or YouTube channel for me to refer to. So what I had during that time was an old anesthesia textbook. The description was, first, I had to palpate and search for the subclavian artery pulsation, and the needle must be inserted just lateral to the pulsation. The direction of the needle must be in BID direction, which stands for backward, inward, and downwards direction. You have to figure out yourself what it means. So when the needle hits the nerve and attached to the nerve stimulator, you will elicit the endpoint muscle twitch when and if the needle hits the nerve. Okay. So I think the hardest part for me was to convince myself there is a plexus beneath the skin and flesh and besides the artery. So basically, I was blind when performing the block. To cut the story short, I was so excited on first, I managed to get muscle twitch eventually. Number two, I didn't cause pneumothorax. So, of course, it was a failed block for some other reasons. And now, we are not blind anymore with the advent of ultrasound-guided regional anesthesia. Now we can visualize the needle and the anatomy of the block area. To be precise, the anatomy of the sonoanatomy of the block area with the usage of ultrasound. And I can see the surge of interest in ultrasound-guided regional anesthesia. And I would say now everyone can block with ultrasound usage. I reckon the biggest advantage of ultrasound-guided regional anesthesia is you don't have to do a guessing work anymore. As long as you can visualize or recognize the correct sonoanatomy, and as long as you can scan the needle tip of the block needle. Okay. So there is a saying that says, if you find yourself in a hole, the next thing to do is stop digging. This is very true in ultrasound-guided regional anesthesia. If you find yourself not seeing the needle, the next thing you have to do is stop advancing. I hope you will remember that in your future block practice. Lastly, to you all out there, remember that you are the future of RA and enjoy the workshop in the virtual manner. Thank you.
Thank you, Dr. Hidayah and Dr. Amir for the inspiring speech. So everyone remember Dr. Amir's wise words. If you don't see your needle, stop digging. Don't keep advancing, okay? So now to start with our first lecture, I would like to invite Dr. Shamala, who is our emergency physician in Hospital Kuala Lumpur with a special interest in regional anesthesia. Dr. Shamala graduated from Kirk State Medical University and did her postgraduate studies in University Kebangsaan Malaysia. So please welcome Dr. Shamala with our first lecture, regional anesthesia setup and experience sharing.
Good morning, everyone. Welcome to the virtual ultrasound guided regional anesthesia workshop 2021. As of late, we have been receiving many inquiries on the RA services setup at our facility. So today, I would like to take you on the journey of our startup, setup, and launching of ultrasound-guided regional anesthesia in our emergency department. The outline of this session will include an introduction, objectives, a little about us, indications, setup, training, and credentialing and privileging. So, RA services, particularly in the emergency department, is an evolving renaissance. However, according to Andrew Herring, relatively few emergency departments have actually fully embraced ultrasound-guided regional anesthesia in their daily practice. According to Herring, emergency physicians are keen to master and incorporate this additional skill set in their repertoire. Establishing this faculty required preparation and commitment. And a multidisciplinary collaboration has proven to be a mutually fruitful partnership for all parties involved, expressly the patients. So according to Alexander Stone, failure of this collaboration could lead to delays in the development and implementation of patient-centered, safe procedure care and limit patient access to the benefits of regional anesthesia. For us in EDHKL, the objectives of starting ultrasound-guided regional anesthesia was, first of all, to provide an alternate modality of pain relief focusing on trauma cases, to provide safe and reliable and efficient techniques, to increase pain management efficacy and reduce the usage of opioid analgesia, and last but not least, to create an appropriate management pathway for post-procedure follow-up and collaboration with primary team. This is us. The picture was taken during one of our collaboration workshop in 2020. Disclaimer, this was all during pre-COVID era. So a little background on us. We officially started in October 2019, pioneered by our consultant emergency physician critical care, Dr. Shafi'i. A core group was formed encompassing emergency physicians and medical officers with basic ultrasound proficiency. There were a total of 3 emergency physicians and 9 medical officers. Our mission was simple: to provide an alternate modality of pain management and minimize the use of opioids. All of this done with the collaboration of the anesthesiology department, particularly the regionalist of Hospital Kuala Lumpur. So first of all, we started off with in-house training. So we had lectures on core principles of UGRA or ultrasound-guided regional anesthesia, anatomy and sonoanatomy, and clinical applications. We had hands-on practical sessions for basic applications of UGRA. We had regular discussions and development of lecture materials on core topics. All of this, again, was guided by our critical care consultant in the emergency department. Our one and only major support was from our anesthesiology colleagues, especially the regionalists. We scheduled attachment in rotation for our core team at the OT, where we had a chance to perform ultrasound-guided regional anesthesia under supervision. The OT attachments lasted for about 2 weeks each. This hands-on training was crucial in developing our skills and, of course, confidence. Disclaimer, with the pandemic on the rise at that time, we did encounter some difficulties in completing the OT training for all of our team members. With this new skill in tow, we started actively performing ultrasound-guided regional anesthesia in the ED, initially under supervision of the regionalists who were kind enough to come downstairs all the way to ED every time there was a case. The indications we focused on were acute pain management of the extremities, anesthesia of the extremity for procedures, alternative to procedural sedation, alternative to narcotics in certain patient population, especially those with head injuries or patients with concomitant mental status change. Ultrasound-guided regional anesthesia was used as an alternative analgesia in upper limb fractures, lower limb fractures, and rib fractures, and in procedures such as chest tube insertion, CVC insertion, and closed manual reduction or CMR. So, the common blocks that we performed were usually upper limb blocks such as supraclavicular, infraclavicular, axillary, interscalene, and mid-forearm blocks, and lower limb blocks such as femoral, popliteal, fascia iliaca, and truncal blocks such as ESP and PECs. So, what are the benefits, you may ask? Well, analgesia can be targeted specifically to the region of pain, and it can provide relief for many hours. It's an alternative to procedural sedation. It decreases ED length of stay, shortens post-procedure observation periods with reduced need for ED nursing care, and it has proven to have high patient satisfaction. So, this is a procedure overview of a typical case. We usually perform RA in the trauma bay located in the yellow zone or in our RA suite, which we will look at a little later. So ideally, it starts with patient selection. So this is crucial to choose a patient that is right for you to perform RA. We get consent, we do the necessary preparation, and then finally execute the procedure. Post-procedure, you have to evaluate the success of your block and look out for any complications. So monitoring is required. And then we have our documentation, both in the patient's case note and our own database. And finally, upon discharge or admission, we follow up each and every of our patients. This is our UGRA form that each patient receives upon receiving a block. It's modified from the anesthesiology RA forms. To date, we have performed roughly about 120 cases. This is our RA suite. You can find this room in the yellow zone in EDHKL. So this is where we store all our equipments, including our ultrasounds and database. Later in this course, you'll get a sneak peek of this space. This is our block box. This is the block box that's used to perform ultrasound-guided regional anesthesia on patient bedside. So we have all the necessary equipments in here that includes needles, syringe, LA agents, atlases, drug dilution tables, toxicity and nerve injury pathways, and references. Right. Now let's talk about post-procedure follow-up. We monitor all our patients for results and immediate complications. So anesthesia should typically be achieved by about 15 minutes. So we monitor these patients for at least 30 minutes to 1 hour following the block. Also, don't forget to inform other healthcare providers that a nerve block was performed and patient will have no function of that blocked extremity for up to 8 hours. For patients discharged, instruction is given on expected block recovery and complications for them to look out for. We follow up all our patients, those admitted, we see them in the wards the next day, and those discharged, we do a teleconsultation in the next 24 hours. Or we review them in our review clinic if assessment is deemed necessary. We also have pathways for each specific complications that my colleague will explain in detail a little later on. This is a follow-up form, and during the review, each of these patients will receive this form whereby we will fill up the patient's details, indicate the types of block they have received, the success rate and the assessment of the block, and we will focus on any possible complications that the patient might have encountered. We further strengthen our understanding during the RA workshops. We have biannual workshops, and all of this is done in collaboration with the anesthesiology department. So our format is simple. We have lectures and we have hands-on skill station. So we focus on training primarily the core team initially. So once all the core team members were trained, we started training all emergency physicians in EDHKL. An expansion of trained personnel in the emergency department with each courses that followed. So the topics of focus varies with a different level of difficulties. So we had our simple, less complex upper limb and lower limb blocks. And we also had truncal and central and neuroaxial blocks. We had stations including the upper limb, lower limb, truncal, central neuroaxial, and vascular. These are the courses that was conducted in 2020. So you can see in comparison from early 2020 to late 2020, the number of participants have increased many folds. This is quite a clear indicative, the interest that is there and the willingness of doctors alike, emergency physicians, medical officers, to learn this new skill and master this new art that they can use in their daily practice. The next, we will talk about credentialing and privileging. So for all our core team members, yes. Next, we'll talk about credentialing and privileging. So for all our core team members, we have an online logbook in commission. How do we do this credentialing and privileging? Well, we divide it into different levels of difficulties. So we have level 1, 2, 3. And in each level, we have specific blocks that are assigned. So for each block, each member is supposed to observe 5 blocks, perform 5 blocks under supervision, and perform another 5 solo with no complication. So once that individual has completed the blocks and is able to actually perform the blocks solo and is credentialed and is confident, only then we would deem them privileged to perform that particular block. This is the example of our online database whereby each member has a spreadsheet that they can fill the patient's detail in. So we have upper limb blocks, truncal blocks, and lower blocks. And all of these blocks is divided according to what we find complex and what are more simpler blocks. So there's different levels of difficulties. Okay, going down memory lane. Well, these are different collaborations that has happened throughout the year between emergency department and anesthesiology. So this was initially done in 2017, and we had one in 2019. And in 2020, when we almost just officially launched, we had 2 separate courses, one in February 2020 and another in late 2020, which was in about November. And we had a practical session in December of 2020. As you can see, we work well and we have very good multidisciplinary collaborations. And the anesthesiology colleagues have been kind enough to share a lot of this knowledge with us and help us train and build our confidence in performing these procedures in the emergency department. So this is a picture of one of our training sessions in the OT. As you can see, this was done in the regional anesthesiology bay in the operating theatre. This is another picture of our training sessions. So this is a skill station on identification and cannulation of the needle. So I've come to my last slide. Our take-home message. Well, first and foremost, do it at your own pace, according to the resource that you have at your facility and the manpower that's available to you. You can always start small and expand as you grow. Secondly, multidisciplinary collaboration. I can't stress enough how important this is. We have learned so much from our regionalist colleagues, and having a good relationship among these disciplines is really beneficial for all parties involved, and again, especially to the patients. Prepare and be mindful on the framework of your service. Envision your patient's journey, receiving RA, right from the selection all the way up to their follow-up. And finally, last but not least, this is a new skill set. So training is very, very important. Every day we learn something new and we learn it together. That's what makes it fun. And it is a novel skill set. So to most of us, this is new. So we have to keep at it and practice and practice and practice to perfect our craft. So thank you very much for your attention. Remember, teamwork makes the dream work, and enjoy the rest of the course. Thank you.